Welcome to this webinar on hemifacial spasm. My name is Dong Kim. I'm the chair of neurosurgery at the McGovern School of Medicine at the University of Texas in Houston, and I also direct the Mission Neuroscience Institute. Today, we're going to talk about a condition that is not common, but something I see a fair amount as part of my practice. And if you are suffering from this, or you have a family member or friend that's affected, I hope that this information will be helpful to you. And I will try to cover what hemifacial spasm is and the treatment options. So first, it's an involuntary contraction of the muscles of the face, like you see in this picture. It can start out and be very subtle, or it can be quite strong like this. It usually starts out occasionally as a twitch, and you think what's happening, but then it can get to be very pronounced. You can't do anything to stop it. It just happens automatically. And it sometimes can be painful, but the primary part of this is not pain, but the spasming of your facial muscle. I'm going to explain to you how it is that this happens. It can be pretty disfiguring, embarrassing. You can imagine how hard it would be if you're at a meeting or speaking and your face is twitching. And so it's a significant condition, although not life-threatening. So I'm going to use this mouse pointer to kind of point things out. And this is a diagram of the nerve that moves the muscles of our face. So a lot of the nerves do different types of function. A motor nerve is a nerve that will, when you fire it or when you think, will move a muscle. A sensory nerve is a nerve that receives sensation from touch or pressure or cold, and then it transmits that to the brain. And for the muscles of the face, the nerve emanates from a part of our brain called the brainstem and comes out through our skull and goes to, in different divisions, to move our forehead, the muscles around our eye, and specifically in terms of closing and opening our eye, our cheek, and down lower in terms of even down the angle of our jaw and whether we can frown or smile and so on. And because it goes to the face, this nerve is called the facial nerve, and it's a motor nerve. How do we make the diagnosis of hemifacial spasm? Well, it's a clinical diagnosis. That means when you see a patient with hemifacial spasm, it's pretty clear that that's what it is. Now, there are other movement disorders, or where people get tremors or spasms that can affect many different areas, and that might involve your arm and your face, and that's a different situation. But when it's just on the face and just twitching of the face, then it is pretty clearly hemifacial spasm. So this is not a diagnostic dilemma. What causes hemifacial spasm? And I'll go into this in some detail. It's a vascular compression, so that's mostly an artery that has moved into a position where it is now contacting the facial nerve, when it should not be in contact. It should just be around the facial nerve. And then the pulsations of the artery, because our arteries pulse with blood going through, can get in rhythm, and it causes a triggering of the facial nerve. So when the facial nerve gets triggered by the artery compression and it fires, the result is an involuntarily twitching of the face. In a very few cases, I've seen a tumor push on the facial nerve and cause twitching as well, but that is very, very uncommon. And in my whole practice, I maybe have seen 2 or 3 patients like that, although I've seen a fair number of cases of hemifacial spasm. Your doctor may order an EMG. It's really not that helpful. An EMG is an electrical test that shows your muscle is actually contracting. If it's combined with a nerve conduction study, it could often show that the nerve is normal, which is what it is in this case, or it may show something else. But if it's pure hemifacial spasm, it's unlikely to involve a pathology of the nerve that's picked up on an EMG or nerve conduction study. So I don't order it. But an MRI is important, and we get an MRI in every case because if there is a tumor or some other abnormality, even though uncommon, we need to know what that is. So this is a picture of the vascular compression. On the left is a picture from below of our brain stem, and all of these nerves that come down out of our brain and goes through the skull and into our head. So these nerves go to our eyeballs, for example. These are our smelling nerves. Our facial nerve is down here. And I wish I had found a better picture that can intersperse, but running outside but near all of these nerves in a pattern are arteries. And these arteries come and feed our brain. Okay, so it's normal to have arteries, and it's normal to have arteries near all of these nerves. Okay, and they float in a space full of clear fluid called cerebrospinal fluid. And they can be near the nerve, but they shouldn't be in contact. So this is a schematic of a patient. And to see the facial nerve, we do a surgery that's behind the ear, and we gently remove a part of our brain called move part of our brain called the cerebellum, which is right here. And when you move the cerebellum, you see a complex of nerves. This would be it. And it's called the vestibular cochlear complex, or the 7th-8th nerve complex. And in these 4 nerves, we have the nerve that moves the face, the nerve that we hear with, the auditory nerve, or the cochlear nerve. And then we also have the nerves that are involved in our balance, called the vestibular nerve. This is the facial nerve right here. This is an artery that down here is near the nerves, but not really touching it. And it really should be, for example, running along like this, but somehow it got positioned as actually contacting the nerve. And then as the artery pulsates, as the blood goes through, sometimes that pulsation triggers the nerve to fire, and then you have the spasm. So what are the risk factors? So this is an uncommon condition, and there are probably not many surgeons that see more than a handful of these patients a year. It's about 1 in 100,000 people. It's more common in women over the age of 40. We don't know exactly why. It just has something to do with our anatomy and the way our vessels are formed, and it is more common in Asian populations. We already talked about it can be caused by tumors and sometimes by injury. Usually affects only one side of the face, and there are a very few patients whose families are affected by hemifacial spasm. So there must be some sort of genetic predisposition, whether it has something to do with the way the arteries are formed, or they're longer or loopier and more likely to make contact, or something else. We don't know, and it would be nice to get a genetic finding or a cause, because then it would help us understand the disease. But at this point, we have no such knowledge. So what are the treatments? Some people try carbamazepine, which is an anti-seizure drug. It runs by kind of suppressing brain function altogether, including the facial nerve, and by making it a little less active, maybe it's less likely to fire. I don't think this is, in my experience, a very effective treatment, but something you can try and see how it goes, because the risks are low, but the side effects are very high. Okay, so because it's a seizure drug, when you take carbamazepine, especially in higher doses, patients feel like they're living in a brain fog. Their memory isn't as good. There are a lot of side effects. And the good news is if you stop the drug, it goes away. So that's not a risk, and you can try it. But while you're on it, you're likely to have those side effects. And like I said, and it's just a symptomatic treatment, because if you stop taking the medicine, of course, then your spasms will return or get back to where it was. So it's not a cure. The next treatment, which a lot of people do, is botox. Because it's twitching, they'll try to put some botox, which paralyzes the muscle and can help with the twitching. This can be most effective for mild hemifacial spasm, and particularly for the twitching that mainly happens around the eye. But this is not a treatment that should be used for more severe cases and not something that should go on for a prolonged period. And the reason for that is that if the hemifacial spasm gets bad, the face can start actually getting paralyzed, okay, or weaker. And I see patients all the time with severe conditions come and they have a droopy mouth on the left, or they have trouble closing the eye completely, because eye closure is an active movement of contraction of the muscle that closes it, and different muscles actually open the eyelid. And so you can try a little bit, but if you're using it a lot and you're starting to get weak, that is not what you want, because there's a treatment that might be able to get rid of your hemifacial spasm, but not lead to any paralysis. Okay, and then the only potential curative operation is called microvascular decompression. And some of you may have heard of trigeminal neuralgia, which is a face pain condition because it involves a sensory nerve, but that condition is almost identical to hemifacial spasm in that it's a artery touching the nerve, and then when you move the artery away, then the pain goes away, and in a very similar manner, and that's a very common condition, and I do 2 of those surgeries a week. The hemifacial spasm I probably do 1 a month, so that's the level of difference. But the approach is very similar, and the results can be very similar. So in the next slide, we're going to talk about how this works, and then particularly botox. So this is a picture of the kind of injections that a doctor would do around your eye, and I think if you're having a mild condition and you want to try this for a little bit, I think that's absolutely fine, but this is not something to do for years or keep doing as your face is getting weaker and weaker. And in this schematic of the brain, you can see the arteries that are shown that are normal, and this is the area we would focus on if an artery is contacting your facial nerve. Okay, and the treatment, because these arteries are mobile, if this is the facial nerve, is just to move the artery out of the way. That can be done very easily. There's no risk to it. And that's called a microvascular decompression. So it means moving the vessel and decompressing it from the nerve. And then because they are mobile, we can't just move it away once because it's liable to move back. So then we take a little piece of Teflon. It's an artificial material. It feels like felt. It's actually called Teflon felt. But this material is not reabsorbed by the body. And we put that between the artery and the nerve so that the artery can't directly touch it anymore. It's not the pressure, because the Teflon has some pressure too. It's the pulsation, and because the Teflon then dampens the pulsation on the nerve, then you get relief. And the artery can be here. Sometimes the artery can be even in what we call the canal, where the nerve goes through, and there are different areas of contact. But if we find an artery contacting it and then can decompress it, then the treatment is very effective. There are a very few cases where we do not see such an artery, and we don't know why a patient is having hemifacial spasm. It really is a mystery, and that has happened to me a few times in my now fairly long career, but that is uncommon. Most of the patients that go to surgery, the vast majority, over 90%, we do find an artery. So I'm actually going to show you right now a video of what this looks like in surgery, okay? And we're looking under the microscope. This blue blob is my hand with a blue glove on it. To orient you a little bit, the patient's ear is right here. So the surgery happens behind the ear because the hemifacial nerve, or the facial nerve, comes out around that part of the head. Okay, the incision is made behind the ear. A little bone is removed right here. It's only a few centimeters, not a big bone window, that allows us to then gently move part of the brain called the cerebellum. We don't injure any brain to get there. And then that gives me the space to look into. And when I look down, I can see the facial nerve, the cochlear nerve, the vestibular nerve right here. Okay, I'm going to show you a video of what we do, but in this instance, you can already see an artery right there. Okay, and that is abnormal contact. So this is live video. I've got some little forceps coming in. You can see the nerve underneath. There's a little suction in my hand. And those little bands are just normal membranes called arachnoid that you can cut. And I've got a dissector now. And I'm looking around and seeing all of the nerve. You can see how gentle we can be. And because there's that artery, now that's the Teflon felt going in. And we're going to just put it between the nerve and the artery. And you can see there's another one there, and we're going to just do it in both. And then I'm going to put one along the side of it so that there's no places contacting. And actually the facial nerve is in front, or a part that we call anterior. So, and then that felt stays in, and that patient did well. And that, because the patient is lying, the angle that we're coming in, that's actually on the posterior part of the nerve. Okay, what's more common is this next one where the artery is in the front of the nerve, or anterior from what we're looking at. But it's a similar process. You can see me, I can easily move the artery, it's mobile. And when you move the nerve back a little bit, at the beginning I actually glimpsed the facial nerve as a separate nerve. And here I made more of a U-shaped felt because we're pushing that artery down inferiorly a little bit, and there are more nerves here called glossopharyngeal and vagal nerves, and I don't want the artery to touch there. I'm going to dissect in this space and put a felt piece right there so no other nerves get in contact. And then you can see that going in, and we just slide it in, and then just to be on the safe side, I'm putting one more all the way around, and so that all of the nerve gets padded and no blood vessel can touch it. And that's the surgery. And I should talk before getting to the last few slides about risk. You know, you can have injury to the facial nerve with this surgery and end up with some weakness. I have not had anybody have complete paralysis, and if there is some weakness, it tends to get better, and it's uncommon, but that is a risk. And you can also lose hearing. The cochlear nerve is much more sensitive, and even with that little manipulation, it is definitely possible that hearing could be lost. But on the other hand, the benefit is the cessation of these spasms. So unless it's, you know, mild, patients really want to get rid of the spasm if possible. So what is the best treatment? Well, unfortunately, sometimes I see patients that are very elderly or very sick with heart disease or other conditions, and in that case, you know, the surgery has higher risk, and we have to consider that, and we have to see what the patient wants. Obviously, we don't do surgery generally when it's very mild, or sometimes when it's starting, the spasm is so indistinct that it's barely noticeable, and it's not bothersome to people. But as it gets to be more severe, that is something we have to consider and help. So that's the end of the presentation. I have a few questions that I'm going to answer, and then we'll go ahead and end this session. So first, is DBS a potential treatment? The answer is no, not for this kind of condition. It can be for other conditions, but we don't do that because that is a more involved treatment. It involves going into the brain. It involves having a stimulator in on the long term, and because there's a more effective direct treatment, that's what we do. Does the felt disintegrate or need to be replaced eventually? The answer is no. The only problem I've had with the felt, and I've probably placed this in upwards of 600, 700, 800, maybe 1,000 patients in my career for both trigeminal neuralgia and this, is I have had one patient develop an allergy to the felt, and we had to go and remove the felt and put in some other material. So it can happen, but it's exceedingly rare, certainly less than 1%. Is sensation loss a potential post-surgery? I can't say it's not possible, but it would be highly unusual because we don't manipulate and work on the sensory nerve here, just the movement nerve. But we do manipulate the hearing and balance nerves. When you mention hearing loss, how serious can it be? It can be complete loss of hearing on that side. I can't tell you the exact numbers, but my guess is it's on the order of 20 or 30%. So not trivial. And in full disclosure, my patients know going in that this could happen. And the only thing I would say is that, if somebody had already deafness in the other ear, that would be a huge consideration. But, that hasn't been an issue in this patient population. And, if their spasm goes away, the patients are happy because that could be such a problem. Is this type of surgery something an HMO type plan could cover? Well, the answer is yes. This is a standard accepted treatment. It's just that not too many people do a lot of it, and there are some doctors who may not even know it's a possible treatment. But, insurance should not be an issue, and I certainly, as a physician, don't like having to worry about those things, although it's the reality. The main thing is we are here for you and to try to help. How long after surgery do patients normally see a change? Yeah, that's a very good question. When I do trigeminal neuralgia surgery, they usually wake up from the surgery and they say, oh my gosh, the pain is gone. I can touch my face and so on. With hemifacial spasm, it tends to take a week or sometimes even longer for the nerve to settle down. So I tell my patients that up front, and even if you're twitching, a few days later, it does not mean that the result's not going to be good. And some patients I've seen wake up and they're already better, but it can take a while. So I think those are most of the questions. I thank you for tuning in.